All right, so it's about 10:05. So let's go ahead and start with the highly missed questions, and then we will proceed on to any questions that you have. I've already started the recording, which is one good thing, because the one thing I want to mention in the beginning is just kind of me reflecting on Wednesday's Q&A. The questions you're going to receive for the comprehensive are not going to be the same questions. So think about the things that we have not asked you already. Those would be the things that I would make sure that I review and know. So some of you did not study like the human development and, you know, the genetics and so forth and so on. So I would be looking at those things, you know, looking at your exemplars. And so some of those exemplars was like Huntington's disease, Down syndrome, autism, ADHD or ADHD, yeah. So I would be going back and looking at those things so that way you understand that this is going to be a comprehensive review of everything from start to finish. So I would not hang all of my laurels just on the, you know, just what you've already seen, because if there were concepts or exemplars that we did not test, they will more than likely show up on this comprehensive exam. You know, contraceptive methods, things of that nature. So, you know, what is the purpose of condoms? What's the purpose of, you know, the Depo-Vera shots? What's the purpose of IUDs? You know, how do they work? Yeah, I'm talking. Can no one not hear me? Because my microphone, oh, okay. So Kavita, you might want to unmute your own computer. Because that would have been tragic if I was doing all that talking just to my office furniture. I don't think they mind. So just kind of, you know, reflect back on those things, and then always start with the area that you were the weakest in. That would be where I put the most of my study time to close those gaps on concepts that I really didn't understand all that well. So with that being said, we're going to kind of kickstart this with addressing concussions. So if anyone has a concussion, and this we'll do adult and then we'll do kiddos. What are some concerns post-concussion? So first off, has there been anyone in this group that either has had a concussion or knows someone that's had a concussion? Okay. So if you were a part of that management treatment, then what types of things did they give as far as teaching? What would be things that, you know, that you witnessed in the care of that person? And not just teaching, just all of it, all the way around. Okay, don't drive. I like that. Yeah, try to keep them awake, have somebody monitor them, right? Okay, so get some rest, okay. Uh-huh. Nausea, vomiting, right? Decreased mental status, headaches. So those would be all the things that you would be looking for or you would be monitoring for. You would also look at things like, now if they were in the hospital, you're still going to be looking for some of those signs and symptoms like nausea, vomiting, the headache, any blurred vision, any changes in mental status. But then if we are looking at how to treat it, then since it's a head injury, what is a concern we would have with head injury folks? Okay, ICP, all right. What else? We talked about decrease in LOC. Okay, they could have antegrade or retrograde amnesia. Okay, they could have either one of those. Okay, respiratory drive, especially if it's a severe concussion. So, you know, we're not really sure how it's going to shake out. What about seizure precautions? Would that be something, especially in the kiddo, that you would want to monitor for? Okay. So with all neuro folks, whether it's concussion, whether it's a bleed, whether it's a, something like that, anyone with an increase or potential for increase in intracranial pressure, where do we want the head of bed to be? We want to elevate it 15 to 30 degrees, and that will help to decrease or reduce intracranial pressure, correct? So, the seizure precautions is safety. Then we're going to be looking, doing our assessment. We're going to be monitoring the alteration of mental status, pupils, and things of that nature. And so basically, in saying that, what are we really, when we're assessing vitals and we're doing the pupillary check and we're doing the alteration of mental status, what is that assessment called that we would actually be doing? Neurologic assessment. So that will be a part of our care. Whether they were an adult or a kiddo, we're still going to assess vital signs. We're still going to double check that neurologic status. Hey, do you know where you are? Can you tell me your name? We're going to check pupils. So all of those things we're still going to be doing. That's part of the assessment overall with someone with a neurologic emergency. We're going to be looking for headache. Yeah. Are you there?
Yeah, can I add a PD note?
Yeah, go ahead.
Sure. So in children, it's probably one of the key assessment as far as picking up just little things is a change in behavior. You may not see change in level of consciousness as such, but a child who doesn't want to play, who isn't responding normally to mother, or a 2 or 3 year old that you go to pick up and they don't care that you're the stranger, those are red flags. So when you're looking for young children, a toddler, preschooler, you're looking for that change in behavior. That's not what you would see in a child. So that's going to be a key assessment for that.
And that would be a part of the neurological status,
yeah.
I think is what you're trying to say, but it's just slightly different compared to that
yes.
of an adult.
Yes.
So, that's what, overall, that's how you would manage that particular individual. Okay, so contra-coup injury. What area of the brain is that more likely to affect? Okay, occipital. All right. So, kind of know if they have a frontal head injury, how would that patient present? What would be their deficits? So when we first started intracranial, I gave you the picture of the brain and I told you the different areas for which they service, or, kind of their like frontal. If there's a frontal head injury, that person is going to ask repetitive questions. Even if you've answered the same question already, it's going to be the same question again. So just be prepared. Don't even get upset. Okay. So, knowing if this is a temporal lobe injury, what would be the deficits that you would expect the patient to experience? And then even if it is memory impairment or vision issues, what are those visual disturbances? So the visual disturbances, and vision is a broad term, but now you need to get kind of to the teeth of it. What would the additional pieces be? Because a patient may say, the patient's going to come in saying, I have blurred vision or double vision or something of that nature. So those are the key words you want to know or understand when you're in front of your patient. What exactly are you looking at? And then if someone does have a, say a blow to the temporal area, and it actually lacerates the middle meningeal artery, what injury is that? That is an epidural hematoma. Okay, so is this a minor emergency? Is this urgent, or is this emergent? Which one of these is it? okay, this is a true medical emergency. So we don't have time to be fiddle-diddling around. We have to be on our, be on our game with our assessments and reporting things that are abnormals. So, understanding that these bleeds, or even if it's a collection of blood in one spot, this is a true medical emergency, and people do, and since this is the artery that's involved, the patient can definitely die, and relatively quickly. So, I mean, just identifying things that are, emergencies that you need to respond to quicker. All right, so since we're still on TBIs, again, patients hit in the temporal lobe. So what type of deficits would you expect the patient to have? So what would be their complaints with a temporal lobe injury? Okay. Difficulty comprehending, okay. All right. And then with any TBI, they always have the risk of what? Because I just talked about it with concussion. There's two different types. And amnesia. So, TBIs across the board, especially at trauma, when I'm speaking trauma, when I say TBI, that would be things that you would want to, pay attention to, because the temporal lobe controls the hearing, the language comprehension. It stores and it's responsible for storage and recall of our memories. So if they have difficulty comprehending language, difficulty hearing, amnesic events, then that's going to be an issue. Patients with frontal lobe injuries, we would expect them to have more personality changes and difficulty speaking. Anyone that has something happen to the cerebellum, that's your gait. So you would expect them to have difficulty walking of some magnitude. So that, again, just going back and understanding, what injuries, how would the patient present if this portion of the brain is actually injured. Yep, antegrade and retrograde amnesia. And remember, the easiest way to remember those two is to take off amnesia. It actually tells you exactly what the patient remembers. So in antegrade, they remember everything before the injury and then up to the injury. And with retrograde, that's antegrade. Retrograde, they remember everything after the injury. So they don't remember anything before and up to the injuries, everything afterwards. So how I remember is I just take amnesia off and I know exactly what they remember. And that's the part that I understand that they're going to be able to tell me. Okay. So what is a complication of a head injury? And this is actually a level 2 concept. So when you have a head injury, so they can have DI or SIADH. So those are the two conditions that you have to be mindful about when you do have traumatic brain injury patients. And so you need to know the signs and symptoms of if they have DI or SIADH. What would be the presentation of diabetes insipidus, which would be that polyuria or excessive urination, polydipsia, and because of that polyuria, and they can actually become extremely dehydrated. So other electrolytes besides the hyponatremia would be hypokalemia. So you need to make sure you review your DIs and your SIADHs related to head injuries and cerebral edema, because remember, that is also a level 2 concept as well that we spoke about. Okay.
Ms. Hudson?
Yeah.
So a person could have both SIADH and DI?
That's not what I said. What I'm saying is with a head injury, they can have either or. But what I'm saying is you need to understand that with a head injury, one of those two conditions may present. So you would be looking for signs and symptoms of either one of the two. Does that make sense?
Yes, ma'am. Thank you.
Okay. All right. Any questions thus far? Okay. So thank you for asking for that clarification. Okay, so again, back with strokes. So signs and symptoms, what types of signs and symptoms would your patient have if they had? And we're just going to go with an ischemic stroke. We'll just start there first. Okay, weakness. All right, paresthesia, facial droop. Okay, dysphagia. They can have hemiplegia. Anything, slurred speech. Okay, difficulty holding items. All right, so if you loss of function, that is true. So if you have an individual that has had a stroke and they're having impaired communication, what would be our interventions? What interventions can we do for these folks related to speech? Okay, dry erase board. Will we always have one of those? No. Okay. So, when you're testing for HESI and NCLEX and even nursing exams, usually those always and nevers are not the way to go, because if you can find one thing to eliminate an always, then it's a wrap. Okay. Give them time to speak. I like that. Assess their ability to actually comprehend the language. Can they understand what you're saying? And sometimes they can actually understand what you're saying, but they just cannot communicate it back. Give them simple instructions, be very concise. I like that too. It's amazing, people may have a stroke and you find folks are yelling at them. They don't have a hearing deficit. So they just can't communicate because their speech has been affected. The area of the brain that controls speech has been affected. So we just have to work through that. But you are going to spend some time with these folks. So you're not going to be able to go in there and hit it and quit it. You're going to have to go in there and anticipate that this may be a while. Yes, Kristen.
So when we're trying to assess their understanding, will we just hold up two objects and say, is this and is this that? And I mean, how would you, if they can't speak, what's the best way to do that?
So you can either do blink once for yes, blink twice for no.
Well, yeah, that's a lot easier, isn't it? Okay,
No. I mean, you're asking the right question. So, I mean, I don't have a problem with that. You probably didn't think about just blink once for yes and twice for no. At least they understand what you're saying. So if you can, can you understand the words that I'm saying? Do you understand that, the sky is blue? Okay, blink yes once for yes, twice for no.
Okay, thank you.
So that way you understand what the patient can do. Now, if the patient can talk, then let's see how much of this talking they can actually do. Let them do some talking to you. Rebecca, you did that in clinical. Yeah, and we don't really think about it. We really don't. We sit there and we make it more complicated for ourselves. We're trying to get all these pads and all this other kind of stuff. It's almost like, before you bust the window to get into the house, check the door and see if it's open, or even to get into the car. So same thing. So all good points. So good question, Kristen. All right. We move around to the next one. And Mrs. Johns, feel free to jump in at any time. I think so. I'm still monitoring, okay, I'm monitoring people still joining. So I have about 3 windows going. All right, so.
Did we answer the printed materials one?
Yeah, we did. So
Okay.
basically they could, oh, was there a question? Printed materials, would that be appropriate? Yeah, you can have printed material, but you need to understand the patient's reading level. So it depends on what type of printed material you would provide, Thomas.
Yes, and you can't say again that that would be the cure-all for everybody, that everybody, if you give them something to read, they're going to be fine. You've communicated.
Right.
For everybody. So it's a possibility, it's an option, but it's not always going to be appropriate.
That is true. And that the other piece to that, anytime you're going to give somebody printed material, and before I even say what I'm going to say, do not shoot the messenger. And I mean this sincerely, but this is really the truth. I know in practice it does not happen this way, but it should. And so what I'm saying is, when you get ready, and I'll answer those 2 questions, Courtney and Tom, just hang on. When you give somebody printed materials, and we do this upon discharge, we really should be checking to see if this patient would even understand these printed materials. But we give it to people and you know, do this, 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 this. And if a person doesn't understand, what is the more likely word they're going to say to you when you ask them if they understand? They're going to say yes. So just be mindful of that. That's what I said. Don't shoot the messenger. I know this doesn't happen. It was an answer choice and a select all that applied. That's why we were curious. Answer choice said always. That is true. It said always provide printed materials. And so this may have been before you joined. I said anytime it says always and never, if you can find one instance where this would not be true, then always cannot be chosen. Does that make sense? Or never cannot be chosen. And I will give an example. Do all HIV positive patients develop AIDS? Yes or no? No. Still have Irvin Johnson, Magic Johnson, that was HIV positive. He has not developed AIDS. So once you find one person for which this will be, that will negate that statement, then you can't choose an always. Okay? When would a time? Again, if the person it does not understand the written materials that you're providing. So this goes back to, and that's why I said, don't shoot the messenger. You got to get down to see what their reading level is, and do they comprehend what, you know, can they comprehend what's on this page? So a lot of times we are sending out printed materials, and we are terrible at doing this as nurses. We will give the printed material, the discharge instructions, but we don't even know if the person can actually read English. We have not even assessed that, and we should be assessing that piece first. If sight was affected from a stroke, then those yes/no questions, you can't ask them, can you see this? Because the answer to that's going to be no. So you're going to have to look at other questions. You know, they can still understand, their hearing should be okay. So if they have sight, then we can't give them printed materials. That's not going to work unless you have it in Braille. And I don't know of any hospital, and Mrs. Johns, you can correct me if I'm wrong, that gives out Braille material for the, you know, for people who can't see. I know I meant that was a time. Oh, yes, Courtney. Thank you. That would be a good one too. I guess I was thinking you'd always give it so family and friends could refer to it. That is our thought, Kristen, that, you know, that we're hoping that somebody in the household will be able to read it. But those are the things we should be checking before we actually release them. Does that make sense? So we should make sure that that there's somebody in there that can actually read the paperwork and actually follow it. Patients don't always have a support system, and that's true too. So there's a lot of tangibles and then the untangibles, but we get into a routine. And it's just, we give them the discharge instructions. That's what we do on the way out. You know, we do those last set of vitals, give them a bunch of instructions. And I'm gonna tell you, even being a patient myself, there's been times I've gotten instructions and I understood it at the time, but by the time I got home, I was like, now what did they say? When you're sick, your mind isn't working like that. Your mind is not on nurse mode. Your mind is on, you know, I'm sick and I don't even understand what the heck is going on right now. And you're glad to hear that it's not something significant and you got to take some medications. And then you're like, okay, I hope that whatever they were telling me is actually going to be written on these discharge instructions, 1, or in these medications I need to take 2. Does that make sense? So, you know, even as you, and just kind of think back when you've gone to the doctor and you've been really sick, and when they've given you instructions, you got home, you was like, I don't even remember half of that. So those are things to, or points to consider for, you know, for patients that have communication issues. And even if it wasn't a stroke patient, you know, maybe they had a stroke before and, you know, now they had a head injury, a completely different head injury. And now this whole situation's gotten more complicated and convoluted. So just understand with patients with impaired speech, we just need to make sure we do our due diligence. Okay, so there was some mix up between what decorticate and decerebrate posture is. So let's kind of go through that. So if it's decerebrate, you know, legs and arms are stiff, wrist pronates, feet flex. But if it is decorticate, what's happening? I'll let you guys tell me about decorticate. Okay, arms are to the core. Okay. Bent arms, yep, the arms go towards the chest. Legs are straight. Okay. Yep. All right, so when do you see folks with these types of posturing positions? Okay, so severe traumatic brain injury, brain damage. Okay, which of the two? Neither of them are good. So this is basically the lesser of the two evils. Which is worse, decerebrate or decorticate? Okay, decerebrate definitely is worse. All right. Mrs. Johns, do you want to tell them about your funeral connection to decerebrate posturing? Are you there, Mrs. Johns?
I am here. I have turned my mic on. So,
Okay.
okay, so which one is the arms folded across the chest? Okay. Okay. So when that has happened, when we've put the arms across the chest, what do we usually think of? They're dead, right? We've got their position. Yeah, dead, dead, dead. So when we've done that for them, it's because they weren't able to. Vampires, that's a good idea. I didn't think about vampires. So I always think of the decorticate as we've had to position them. With the decerebrate, what have they done? Decerebrate, remember? Posturing.
So they have the stiff extension of the arms and the legs.
Yeah. Are you going to be able to fold them up? Not so easy. Okay, so that's the stiff extension. And that's, which one's worse? What should you just tell us? The decorticate, right? Or, I mean, decerebrate, because my cerebrum's gone, basically. That may not apply. I should have written it out, so I have a better one in my notes.
Yeah, I thought you were going to tell them about the small coffin. That's why I said that.
Oh. About trying to get him in there?
Mm-hmm.
Mm-hmm.
So, all right. So, you know, you already know more. Nursing has a morbid sense of humor.
Oh.
So I'm going to move on to the next one. All right. So,
Do you want me to say something about meningitis?
yeah, yes, by all means. Are you going to talk about the epithetonis?
The what?
The pot where the back is arched?
Yes, okay, we can talk about that.
Yeah.
I was just going to say, first of all, because I don't know if there's a question on this test for you, or it'll be a question on 4th level as well, so we talk about it some more. But one of the things everyone wants to know, what kind of isolation do they go in? Do you put them in isolation? Should you? And I always look at it as, what is the first part of the nursing process? What is it? Okay. Assess, assess, assess. So whether they're coming into a clinic where we might assess them first, or they're in the ER where the ER nurse and whoever's on call down there, physician-wise, are assessing them, we're taking assessment data and making a preliminary decision. So patient comes in, they've got a stiff neck, they have a fever, headache, we're thinking it could be meningitis. Do we know it's viral or bacterial? Of course not. So we're going to treat them for the big picture. We're going to put them in contact droplet isolation, contact case bacterial, droplet cases viral, until we have diagnostic tools. So we assess first. And then based on that assessment stands until it's disproven by diagnostics, whether it's X-ray, CTs, MRIs, lab values, whatever. And that will tell us for sure. But we're going to treat the big picture. We know it's viral, we can discontinue the antibiotics. We know it's bacterial, we got to make sure the sensitivity is correct. So think of it as a presumptive diagnosis. I know it's a question like that on 2nd with diverticulosis, litis, and we're suspecting litis. So now we're not doing a colonoscopy, we're not putting something up their butt because we're going to perforate it and have peritonitis. So we're going to do a CT scan until I have a definite diagnosis that makes anything else available to do. Does that help you understand the contact part of that? How to isolate? Better safe than sorry. That's a very good principle to put with meningitis. We don't know what it is. But even on the suspicion, we're going to, maybe they have the flu, okay? You know, maybe it's not meningitis, but until I know that for sure. Could also be encephalitis, which is worse. Same thing as your hematoma. I would rather have meningitis than encephalitis. So we're going to have more damage and more complications with encephalitis. Does that help? A little bit, okay. What else do we want to talk about on meningitis? Is that it?
Oh, it was just the posture, but I think they have that posture.
Yeah, I think so.
Something that they would need to report to the physician if they witness that, whether it's a
Yes,
or an adult.
absolutely. And again, remember if you're dealing with babies that you may not have the they don't have, especially an infant, they don't have real necks. I mean, they don't have a big neck that you're going to assess that. So with an infant, your number one indication that it might be meningitis is that bulging fontanelle. The fever with the fontanelle, just like we talked about hydrocephaly. Same kind of thing, you will not see that neck stiffness. So you've got to assess your patient according to the age they present. Local outbreak question, I'm not sure what that is.
I'm not sure what you're asking. Yeah, that wasn't our question.
Okay.
I was like, I don't remember that.
Okay, that's a good point there, that question, bulging, not pulsating. All fontanelles pulsate because we can feel the flow of blood through it still.
Right.
Pulsating is not a problem. If they're excited or something, you may feel it more simply because their heart rate is faster, but it's the bulging, or in dehydration, it's the sunken fontanelle. Pulsating is not a problem. Does that answer? I hope that answers that one.
And they would have a fever with that.
Yep, they will.
So you can have a bulging fontanelle by itself, but that would be increase in intracranial pressure. Mrs. Johns, correct me if I'm incorrect. But bulging with a fever would be meningitis.
Absolutely, absolutely. Yeah. And that would be if you were, and again, if you're differentiating between diagnoses and you're not sure, but you have your assessment and you have a fever with a bulging, you would be more prone to suspect a meningitis. Or you have a bulging and irritability, but no fever, I would suspect hydrocephaly. You've got it, Jessica. Again, you've got to tie into your assessment and make it preliminary until it's proven right or wrong. Is there P&C on the comprehensive? I'll take that one. There's always P&C on every test, just because we don't label it. But if we're asking you to prioritize, to delegate, to decide who you're going to see first or what you're going to do first, those are P&C based within the content of your concept. And the same is true with HESI.
HESI, there will be definite P&C concept.
Yeah, absolutely. Is this an ethical legal thing? Can you pronounce a patient dead? You know, is that a legal thing? Those wouldn't be quite that easy, but there's always tie into P&C. So don't separate it too much, folks.
Right.
Into relationship between the professional nurse and the knowledge base.
All right, so more intracranial. Gotta love it. So what's the difference between a stroke and a TIA? Correct me if I'm wrong, if the ICP is within normal limits, even though it's 16. Yes, you're right, it's still high. So it's transient, it resolves itself, it's a warning sign. Okay, usually resolves in 24 hours. All those things are true. And they can still have the same signs and symptoms that we talked about earlier with the slurred speech, facial droop, etc. So when you have patients that have many strokes, they usually have some medical condition, you know, high blood pressure, high cholesterol. Those are usually things that they may have as a part of it. They could have diabetes. But when you have someone that's, you know, say they had multiple mini strokes within a short period of time, recommendations or recommendations by the family to you, what things would be appropriate for the patient at this time? Should we be thinking about putting them in a nursing home? No. Okay. So basically our focus should be, we know that high blood pressure, diabetes, high cholesterol, those things actually cause strokes to happen, and it is a warning sign. Hang on one second. It is a warning sign, and it's basically saying you need to fix some things beforehand. So if you fix some things, you could minimize your risk potential. That's the word I want to use. So a TIA is a temporary blockage in where either the vessel spasm or there may have been a clot there at one point, but it was able to move forward. So it's a partial block. So it's not necessarily a no blockage.
And I was going to say, you can also see these with patients with atrial fib, with AFib, where they're not anticoagulated sufficiently, and that is a good sign that they need to look at their INRPT, and we need to make some adjustments. So just, it can be a multiple causes, but the key is it resolves, but it's transient. But it's a warning sign. You've got to think, I think you really got to look at it as a warning sign.
So your question's been answered, Stephanie, so I think I don't need to address that. But also look at medications that can also reduce clot formation. And
Yes.
that's if it's an ischemic stroke. Now, if these folks are on antiplatelets like aspirin, and they hit their head, then this is going to be traumatic.
Mm-hmm.
So that brain injury is now, this is going to be another one of those true medical emergencies, because we've taken something that may have, we've had an issue, but now because of, there may have been having a stroke and they fell and they hit their head. Now this is now going to be a game changer. And I think I shared that with you guys with my father-in-law, who had, actually had a 5-vessel CABG, like 15, 20 years before he actually died. But he was having a heart attack that morning, stood up, clutched his chest, went to try to get his medicine, got dizzy, lost his balance, and then hit his head on the dresser. So, he died of a intracerebral hemorrhage. So it was within 24 hours. It was actually less than that.
And I see that was the same thing with my mom on the ischemic stroke.
Mm-hmm.
He took her off trying to get her INR low enough to do a hip surgery, which went just fine, but she never woke up again. And she'd suffered a severe ischemic stroke.
So, you guys have probably come across folks or know folks for which these situations have happened just as well. And I'm just talking about the situation. Management of how you would manage these patients will be strictly based on, what you're learning here in Lippincott, definitely not what you're doing at your jobs. So just kind of, FYI, because there's a little bit of variance there. Embolic and ischemic strokes are the same thing. Yes, hemorrhagic is a bleed, but an ischemic stroke is basically a clot. And the embolic basically means, and it should be thrombus if you really want to be technical with that, Kristen. A thrombus is actually a blood clot. An embolus is a clot that started in a different location
and traveled to another location. So that would be your patient that has had a DVT, so a deep vein thrombosis, and then the clot broke off. And then it traveled to the brain and they ended up with a stroke. So that would be an embolic stroke. It's still a clot, but it's a traveling clot that landed in the brain. Does that make sense? Does that help clear it up? Okay. Yes, atrial fib, what's happening there is the right ventricle cannot push out all of the blood into the pulmonary arteries. Some of that gets left behind. And when blood is left behind and it sits, what happens to it? It clots. So now as the next contraction happens, it is liable to push out a clot and put it into central circulation.
which could land in the brain or the heart or the lungs. So there's several places where it can end up. I mean, it can end up all over the body, but some of your more critical areas. Okay. So that was another one of those questions where I think it may have been misread. The chaplain wasn't necessarily giving the instructions, but was listening to recommendations or questions from the family, and you were being asked to say if these things would be the right things to do based on the fact that these are mini strokes, not the big one. I think we just have about 2 more, and then we'll move on to the next piece. Let me go back to it. So basically, they are not necessarily all in. So they're hesitant. That's what that was saying. So they're not gung-ho. And some, cultures are not gung-ho to put their folks in nursing homes. Some people, it's just, it's like putting on socks and taking them off. So it's different for different people. That wasn't on, I don't think that was on our test. I think that's another PNC test. I don't think that's ours, because I wouldn't ask, we wouldn't put something on there like that. BID, I didn't see that, but remember, I'm covering highly missed, so this may not have been a highly missed question. And it definitely wasn't related to this question. And from where the question where we are, there's only 2 additional highly missed. All right, so let's hit the last 2. Okay. So we have an end-of-life patient that's in hospice. And so okay, I'm not gonna even necessarily use this question, but I'm gonna still give the general gist. So you have a hospice patient, and we're gonna say they have colon cancer and with metastases to the lungs, okay? So now it's asking you to do a chart review. So if we already have a cancer that was in one location and it's now it has moved to another location, what lab values will tell you if it moved to another location? So if it moved to calcium would mean, where would it be going then? That would be to the bones. So if the liver function tests were elevated, then where did it go after that? To the liver. So you have to be able to look at, when you have abnormal lab results, and especially like an elevated calcium in somebody that has cancer, then that cancer has now metastasized to the bone, which we need to definitely report that. That's not a normal finding. Even if it's the normal transition, it's not what the patient had prior. Does that make sense? Or if the patient started to have seizures, then where did the cancer go then? To the brain. So it's understanding that when the cancer metastasized to other locations, we're going to have deficits in other locations. And so we look at lab values, and we look at, patient presentation to see if there's been an additional spread. even in hospice. So even in hospice, Courtney, it's even if they don't do anything, you still will report it because that's something new. That's almost like receiving a critical lab value and say, well, you know, they're DNR, I'm not gonna say anything. We don't have that option. So it's the physician's choice whether he or she still, exactly, if they want to respond to it, it's still a critical lab value and we still need to report it, whether they're gonna, whether it changes anything or not, it's irrelevant.
Remember, even in hospice care, we're going to do measures to keep the patient comfortable.
Right.
So my dad had that, went to the brain, and so he was put on Decadron medication because it was for comfort. It wasn't going to change the outcome.
Right.
But he was having seizures and moaning and very uncomfortable, so we do something for comfort. So you still want to report it because the patient may need something else to keep them comfortable. Yeah.
Well, it's not necessarily ignore, as Mrs. John said. They can find something for comfort to help with the additional. So if a person has bone cancer, that's going to be extremely painful. Mm-hmm. So they may now increase their pain medication. So it's not necessarily ignoring it, but if the person has, if it goes to the brain, then they would give medications to help manage that. Now, are they going to give them anti-seizure medications? No, but they would give it for comfort though.
Oh yeah, I was just saying that was my thought process. Like, why would they even order the labs if they were just going to ignore them? Like, what's the purpose?
I see what you're saying. Okay. So no, it's still end of life care, comfort care, no matter what. So even when they start collecting secretions in the back of their throat, or even, secretions start to increase their body, increase in their body. So like when my mom, when she started having that third space and they gave her some albumin, so that way she would be comfortable. So they just wanted to move it to its appropriate place. You report it. All right, our last one, this is another, this was, and I think I received an email from Alexa, if I remember correctly, but this was the pediatric terminal cancer, and it asked about kind of the, as death was nearing or approaching, what things would be true. So we did need to add an age for that one. So that would definitely be a game changer on which of these would be correct. So you did, all exam takers got credit for that one. So depending on the age range will determine if they're going to have that magical thinking, whether they're going to think that the person's just sleeping, whether, they should be a part of being at the bedside and seeing the body afterwards. I mean, there's, do they really understand it? So, I think, I won't say that I was a chicken crap. I would just say that I kind of sheltered my kids from situations like that until they were teenagers and they could actually really understand it. So if there was, a death in the family, a funeral service or something of that magnitude, then I didn't go to the service. I would go to the repast afterwards. Because, sometimes children really just can't handle all of that. And so they actually appreciated it because, even in recent years with family members dying, some of them have commented back, and I have 3 children, that remember the days when you would not let us go to a funeral? I mean, some people love to go and some people are just like hands off all the way. So you do have to consider how this is going to affect that individual as well. Do they feel that they may be the blame for the kiddo dying? So that a lot of those thoughts and feelings, you know, kind of creep in whether you realize it or not.
And you want to remember anytime you have a death, and I think the question was actually a death of a pediatric child or a pediatric child, it will disrupt the family. It will create change. There's no getting around that. The family needs to be prepared for those changes, whether it's from the other children acting out, regressing, changing, or just the parents themselves can be at different stages of grief. They're not on the same page, and that's going to affect it as well. So you have to look at the entire family, the effect of that.
Or the kiddo may actually regress back to a previous, a previous stage. And when I say stage, I'm talking about developmental stage.
Right.
I mean, if they want to hold, are you talking about should the family hold the baby? Dianelle?
Yes, they should. We
Absolutely.
We offer that definitely. We offer them time. We often have whole families, grandparents want to come in. That is fine. So yeah, SIDS is there is no fault. We've gone to the two major contributions to it, which were sleeping on the abdomen with pillows, and that the sleep posture of the newborn, and the second one was smoking. And the pregnant mom we know has contributed to it, but there's no one's fault. You can't pin it on that. It's very sudden. It's very, I've dealt with enough of those. It's very, very hard. And so it's important that you do allow them time with the baby. If the other family want to, absolutely allow them to pick the baby up, hold the baby. Now you'll have some instances, even with the death on the pediatric unit, where the parents, they feel they've been there for what they could, and they just want you to care for the body now. They don't want to, and that's fine too. And you have to just be respectful of what they ask of you. Yeah.
And you know, that's from the floor perspective, but if you're in the emergency department, you know, that's a whole
different.
That's a whole other ball game.
Yeah.
However, though, you know, having family at the bedside during resuscitative measures is phenomenal.
Yes, it is. Because
it will help transition the grief, and, you know, it'll help that process along. And I can, you know, our first patient where we had family at the bedside was a pediatric patient with a congenital heart disease, and went into VTAC frequently, and was told at some point they would not, one of these VTACs they would not recover from. And it was actually comforting for the dad to actually stop the procedure, but parents being at different stages, the wife wasn't there. And when he said it out loud, she gasped, because she was like, "What do you mean stop?" So, you know, some of those same things happen, however, but there's not a whole lot of grieving time. That grieving time is short.
And I totally agree with that. Having the family there at the bedside helps bring some of those answers to closure for them. Yeah.
All right. So those were your highly missed questions from the last exam. Yes, Kristen.
I have a couple of questions if you get a minute. Is there somewhere we can go, like the question that was saying, you know, patient came in dead on arrival from a gunshot wound, I think, and it was asking about the different roles of the nurse and the doctor. Obviously, I know that we're not supposed to tell them how they died or, you know, explain like that kind of thing, but I wasn't sure about where can we go to find out what our role is in that? Because I was looking in the book, but I couldn't find anything.
It is actually in different places in the book. And I think what ends up happening, it gets buried into like the hospice component and people at home. And then it talks about it in different stages, but it's in different places in the book. And it doesn't specifically say it the way you want it to say it. Because I went back to, to make sure that, you know, that this would not be an oddball thing. But I did discuss that in either the Zoom session prior or during lecture, that we don't disposition clothing. We do collect it, but that's what our chaplain or, you know, the, for when I worked at Methodist, it was the chaplain who, you know, who worked very closely with the family and brought them to the bedside, you know, managed their belongings. And belongings is just not clothes, you know, jewelry, took it to the, to the safe, the hospital safe. That's not the right word, but that's the word I'm gonna use for it. But it did not, you know, they were responsible for getting all those pieces connected and the disposition thereof. So nurses just put it in the bag and it would go with the patient, but we did not do any dispositions after the fact.
Yeah, I remember you saying that, but I wasn't sure about the escorting part. Do we take them to see the family, or is that something a doctor should do in case they have more questions?
Well, usually doctor and nurse goes, and this is how we did it, is doctor and nurse went in together. Doctor gave information, we supported.
Okay. And then, can I ask my second one now? Can you give us a little insight on like trick questions? I mean, I've developed major trust issues from these exams, but like for example, one of our reproduction tests, it was talking about what would you do for a prolapse cord, and one of the options were to cover it with gauze, but they should have been moist gauze, so it wasn't right.
Right,
and
because if that dries out, remember, it's like it's almost like if you had an abdominal evisceration. An abdominal evisceration is where your intestines is actually protruding out of your abdominal cavity from trauma, and it could be from blunt trauma. So if you leave that out to air, then that will dry, and then that will definitely impact the baby tremendously. So if the gut's left out, the person's going to end up with necrotic gut. And so they may end up with a colostomy bag and everything. Does that make sense?
Oh yeah, no, I get the rationale now. I was just, I was trying to apply it to one of the test questions, and I'm probably the only person that got this question wrong, but it was the one about where the gentleman had low saline or hyponatremia, and it was asking what priority was, and I knew that he needed the 5% saline, but I didn't pick it because it said IV and not central line.
So if it says IV, it doesn't necessarily mean peripheral line. It just means it's going to be given intravenously, but we're giving you the extension that because of the concentration of the 3% sodium, then it has to be in a central line. It's still an IV line. Does that make sense?
Yeah.
It's just a type of an IV line. So you could have a PICC line, that's still an IV. You can have a peripheral IV, that's still an IV.
Is there a way that we know that not to read so much into it? Like,
yes,
you know, I mean, with one, I didn't read enough. And
what that's based off of, is it IVPO sub-Q IM? Does that make sense?
Yeah.
So it's not, so for your knowledge, you just need to know if you have to give it, you need to have a big line for that, as big as possible because of the concentration, but it's still IV. It's still going to infuse intravenously. So NCLEX doesn't ask, and HESI, they're looking at, do you know this should be an intravenous delivery? Not necessarily, it should be through a central line, or it should be through a PICC line, because either one of those two would be appropriate.
They're still IV.
But it's still IV.
Right, and just like sometimes people mess up on questions, get mixed up with the word enteral versus parenteral. And enteral simply means I've used the GI tract, whether I've done it through their mouth or through an NG tube or a gastrostomy. It's still enteral. It's still using the gastrointestinal tract. If they can't do that for whatever reason, then it becomes parenteral. So it's through the vascular system. So probably just knowing the big picture of it again, rather than trying to memorize or focus on details. IV is going to encompass all of that. I don't know if that helps, but.
Well, that's what I'm saying. It's just like one I didn't focus enough on the details, and then the other one I'm reading too much into it. So I just don't know how to balance that, I guess. I always feel like You're trying to trick me in some way.
We're not trying to trick you.
Okay.
And that's why, we'll tell you again and again, just keep doing questions so you keep seeing that again and again to become comfortable of how to dissect the question and find what's really important and what it's truly asking. Okay, any other repro questions? Labor, delivery, anything? No repro questions? It is so much. Well, okay, so give me something to answer.
I mean, I just feel like it's so much from like the antepartum all the way to the postpartum. I really just kind of decided to teach myself everything from the point of conception to the point of labor, because it's not very specific. It's very broad, like, so I've just decided to go from prenatal up until conception all the way up until delivery, because I just don't, there's no pinpointing what it's specifically of the labor or the maternity or the newborn preterm. Like there's nothing. So
but there are some principles that are going to apply across the board. Okay, so the first thing, which you already know, but you have to approach that question with, I have 2 patients, and what I do for one affects the other. So I always have to think about that with medication. If I give it to mom, baby's going to be affected. So if I give mom a narcotic and I have a baby 15 minutes later that I didn't think was coming that fast, I've got to have Narcan for my baby because they're going to be opioid depressed. So if I have a perfusion, if my mom is very tachycardic, if they're hyperventilating, I'm going to have them breathe in the cupped hands, etc. But if they're not, O2 sats are dropping, and I put them on oxygen. If my baby is showing decelerations, they're not getting enough oxygen. I still put oxygen on mom. I can't reach up there into through the cervix up into the uterus and plop some oxygen on baby. I'm going to have to put it on mother in order to provide the perfusion my baby needs. If mother has gestational diabetes, gestational hypertension, I have to treat her for that. I have to control that blood pressure in order to protect my baby. So it's the same. Just look, I think if you look at those bigger pictures of it and it applies across, you think I've always got perfusion, oxygenation issues, growth issues, so I'll make sure I have that. And anything my mom comes to the pregnancy with will affect baby. And that is one reason why we do that. Check the blood sugar, glucose testing, and H&H again at that 28 weeks, because that's a key point at which they're going to be low, because baby is growing, developing, and it will take everything it can from mom. So mom's going to have a tendency to become anemic, or we might see the gestational diabetes pop up then. So those are, knowing those time frames, I think, would you maybe understand that?
So, and then, since you talked about gestational hypertension and diabetes and stuff, it also says on this lovely review that we should know the test for the pregnancy. But my thinking and my reasoning is, I feel like we're not specializing in OB, so I don't know how far I should be studying for both HESI and the COM, because I'm like, am I going to need to know every single absolute test that they do in the entire pregnancy, or do I focus on the med portion?
You focus on the 2 big ones, which is your vascular health, hypertension, because that's going to affect perfusion, and your gestational diabetes, because that is going to affect baby's growth. We're going to have, IUGR where they have growth retardation, or I'm going to have a macrosomic baby that's so big. So knowing those things, I think, will help you. We're not focusing on every single test we do now. We're concerned with mainly those 2. If you know those 2 big ones, I would say you'd have the majority of what you would need to know for comprehensive as well as for HESI.
Okay, great. Thank you, Mr.
Did that help you at all?
The one
Yeah.
thing I'd like to add is about the patient
Sure.
population. So the one thing I want to say is about the patient population of HESI. So you can get a pediatric patient, but it covers all of your concepts. Does that make sense? You could get a pregnant patient, but it covers everything from repro to end of life. So treat the condition. And if there's any differences, like we did with, the concussion, end of life care, and things like that, then you would be answering appropriately for that. Does that make sense?
That's exactly. Just focus on what the concept is. And then if it's something specific about that population, you have to apply to it. But primarily, we're going to treat that concept in a certain way. Have a certain goal for homeostasis, whether it's 2 patients or 1. That's our goal, to get things back in order.
So yeah, I didn't want you to feel blindsided. If we're talking about adults and everything we're doing is about adults, but then they give you a pediatric patient, or they give you a pregnant patient, or, your whole population is, middle-aged and elderly. I just don't want you to be like, well, they didn't say all that. Or if this was, a repro question, but the patient had a leg fracture. Do you see what I'm saying?
And I'll just say in the OB, as far as like the pregnancy itself, we're not going to focus on what is happening per week of the growth of the fetus, but we're looking for what would be an indication that something might be wrong. So my mom isn't growing that 1 centimeter every month that we would feel the fundal height should be. Or the mother has bleeding. We know that right away, that's never normal during pregnancy. So it's, I would say, focusing on, because this is our focus for nursing, is how can you recognize, you have to know the normals to recognize the abnormal. What are you going to do about that abnormal? It's got to be your interventions. Sound okay there? But it sort of tagged on to what Ms. Hudson was saying. Okay. Anything else on OB?
Yes, Ms. Johns. If we have a patient that's laboring and trouble arises, cord compression, cord prolapse, and they're taking Pitocin, is it always priority to stop that first?
Absolutely. Absolutely. We do not want that uterus contracting down and totally cutting off our baby's lifeline. So we will stop the Pitocin. You are welcome.
Johns, I have a really quick question. I'm a little nervous to ask it, but I'm just gonna ask it because I paid good money to be here. So, in regards to the OB, the reproduction side, I know that on our exam 1, there was just a little bit, not too much. There was a strip. I believe it was a 10-minute strip. For the,
You're talking about the one with B cells?
Yes. With the D cells. Would that be something, I mean, I've been looking at it, but it's very detailed in the books that I've been reading. So I just know if it's broad, or, like just kind of what they look like and the interventions for it, or is it like specifics?
You need to look at it in relationship to mom. So if I'm seeing things happen during the contraction where it's going down, that would be considered appropriate because the uterus is contracting, there's pressure on baby, and as long as it comes back up and recovers after, as mom's contraction levels going down, I see my baby's heart rate going up, I'm good. If it happens late, if it happens after that, and we're not recovering, that is a cause for concern, and that needs an intervention. I had my veal chopped down, but I couldn't figure out the strip. Look for the lines where it tells you where the contraction is.
Mrs. Johns, did you,
Yes.
if you had a strip, I believe you can share it.
I don't think I do.
Okay.
I might look for one, see if I can find one, but I will look. Know it on the level of the PowerPoint because it's fairly vague. And I wasn't in the third at that point, but sort of my ball game anyway. It should mirror mom's. Yeah, there should be. I think that's probably the key. It should. The baby's heart rate should go up as mom's go down, almost, I guess, inverse. But because mom is relaxing, now baby's got a chance to recover from the work of labor. But we don't like babies going down after a contraction's over. That's never a good sign. That's when baby should be fairly steady. And that often means either we have to reposition, maybe baby's laying on the cord, or there maybe as baby moves its way down the birth canal, that's where I'm going to have problems if there's a cord wrapped around a hand or a foot, or because the baby's coming down and pulling that with them and making that knot that's wrapped around even tighter. So that's why we look at that strip and are concerned with decelerations, that the baby does not recover from the dip. And I will see if I have.
Last question, I promise, from me at least. I hate putting it in this phrase of will that be on the test, but when it comes to category like 1, 2, and 3, I feel like that's very specific. I don't know if we're going to get that specific on the comp, but it was in the OB PowerPoint for decel, so I'm not sure if that's something to remember. I have
But to answer your question, even if it wasn't on the comp, it could be on HESI.
Mm-hmm.
And see, we have no idea what questions will come from HESI. And, you know, we have new HESI exams. So they receive our concepts and then they pull the test together. So I have no skin in the game.
And again, what do you do? What is their nursing intervention? I think you need to, I think they'll ask you to actually read the strip, but you can tell if the baby's heart rate's going down at the end of a contraction, at the beginning, during. That's fairly easy to read. But what are you going to do about it? I think that's what you have to focus on rather than trying to memorize the stages. Okay, so my baby's heart rate varies and comes back. What am I going to do? Nothing. I don't need to do nothing. I might make sure mom's comfortable, but I see this decel happening, popping up every so often. Remember, position mom, see if I can get baby off the cord. I'm not getting a recovery. I've got to get some help. So I really can't give you anything more specific like that than that. As Ms. Hudson said, we don't know what the questions are, but I do know that it's going to be based on what are you as a nurse going to do. That's what we're looking at. Oh, it's still a HESI. Don't freak out, guys.
That's what I said. I mean, what's the new HESI talk? It's no different than NCLEX. The same NCLEX exam isn't given. And if you look at the National State Board of Nurses, I can't remember,
NCSBN.
NCSBN, National Council of State Boards of Nursing, that's what it is.
Yep.
And they actually change the test every 3 years. So, you know, and even within the 3-year window, it's not the same test. So you although there may be somebody in the United States that's taking the same test that you're taking, that may happen, but it's, you know, all of your questions, it won't be an exact replica. So you'll have some similar questions and then you'll have some questions that are different. So I wouldn't be stressing over that. My focus right now would just be, you know, where are my weaknesses? Let's close the gaps on the weaknesses. And again, the comprehensive will give you some more guidance on, you know, where your weaker areas are. And the reason why I'm focusing on that is if you don't close those gaps now, even if you pass HESI with a 900, you still have that gap, you still have that weakness, and then you're going to go into fourth with the same gap, same weakness. And even if you get out of fourth, when you get to HESI, you're going to have the same gap. So let's close it so that way your foundation's more strong. We'll talk about that later. What I need you to do now is to focus on the comprehensive, because that piece is that is an easier transition. So let's not focus on that. And what I find is if you focus so much on the negative happens. So let's focus on the positive.
Amen.
And that is really a true
So
statement.
true.
Because
It is.
sometimes when I can't fail, I can't fail, you focus so much on that your concentration, you literally derail yourself in concentration and being able to understand concepts, that when you actually do take the test, then you can't recall the facts, although you know you read it somewhere, but you can't remember all of the details. It's because you were in that panic mode of I can't fail, that you did not allow for the rest of this to hit long-term memory.
Absolutely.
So you have to allow for that transition to happen. And if you stay on the negative piece, then your brain has already been trained for failure versus being trained for success. So you need to switch the narrative.
Absolutely, because then you're training your whole focus is stress related, and all of that fight flight syndrome is going to happen. And you don't want to be in that. You've got to say, I know this, I've looked at this, I've studied this, what can I add to it? And go from what you know. You know a lot or you wouldn't be sitting here. So you've got to remind yourself that you do know and try to add to that.
Nothing in healthcare is going to be easy, not even for my EMTs.
True.
So my EMTs, they're having that same stressor, although they can't, I mean, you guys are much further along than they are, because they can't, there is nothing in EMS to use simulation, VSIMs, as clinical hours. So they are stuck. So these are EMTs and paramedic students that started in January, and their semester has literally been carried all the way out. And it may be to fall of 2020. No, Michelle, they do them equally. So they don't focus more on repro versus, end of life versus mobility and comfort. They're going to give it equal homage. So yeah, I know you want to try to concentrate your study, but the truth of the matter is there's no shrinkage. I can't tell you don't study this over here and you don't study it and it pops up on HESI. You would be, and I'm just going to be honest, you're going to be hella mad at me. And so I'm just saying, I can't vouch for something I have not laid eyes on, and I will not be able to lay eyes on because it comes from the vendor. For the comprehensive, it's going to be equal homage. And when I say equal homage, so throughout our conversations, and I'm going to keep going back to this because I know that we're only talking about the things that you guys remember, but remember in that first exam, there was, a couple of sections that weren't really discussed or covered in lecture. So just because it's not covered in lecture, it doesn't mean that it's not going to be on the test. It just means there wasn't any room in lecture for it to be covered. That material is still testable. So back to the human development component. So, like your Huntington's, like your autism, like your ADHD, like your Down syndrome, you need to go back and look at those things. So that way you understand, because there will be questions, as I said, that you haven't seen already that will be on the comprehensive. What do you mean? Why was a Zoom not offered for that? I don't know. I can't answer that. Did you guys ask for a Zoom?
I didn't think that I had to ask for content to be covered that was not covered in class.
Okay.
Yeah,
She
I also
has no idea of knowing that that's what you would need if you don't ask her. And I'm quite sure if someone had, she would have obliged. So just, you know, a closed mouth will not get fed. So if you don't tell somebody you hungry, you will starve. So let's not starve. I do the Zoom sessions, I offer them up, but I do things differently than, you know, I'm just gonna tell you, I will do it. You need to participate, you need to, you know, have your stuff ready, whatever the case may be. But I can't expect somebody else to offer it. You know, they may be waiting for you to tell them or to ask them the question, but I'm quite sure if someone had brought it up, she would have wholeheartedly done it. But do you not have PowerPoints already over human development? Okay, so go back and review those. But in your, also you have your concepts with your exemplars. And so if you go to concept view, it's in there in Lippincott. So you should not be blindsided by anything. Yes, Miss Kristen.
Question for Isabella, actually, because she had to work.
Speak up, babe.
Isabella had to work, but she gave me a question for you.
I can barely hear you.
Sorry, can you hear me?
You need to be a little louder. I have my volume on 72.
Maybe I covered it up. Is that better?
That's much better.
Okay, sorry. Isabella had to work, so she asked if I would ask you a question about if you could explain the neutrophils in A and C regarding cancer and which one, I guess she's confused which one to be more concerned about when we're looking at labs and stuff.
Well, you're going to be looking, why are you looking at the neutrophils in the first place? What's the condition?
For cancers and infection?
Okay, we're looking if we need to go on, if they're neutropenic, right? But we're also, isn't it part of that tissue something? Tumor, not tissue, tumor. Tumor lysis syndrome.
Okay.
But we are looking for infectious processes. We're looking to see what those neutrophils are, if we need to go on neutropenic precautions. So, you know, they're going to have a lot of immunosuppression. So we have to be mindful about that, and also look at the lymphocytes, because those are our white cell fighting capacity cells.
Okay, thank you.
All right, so Michelle answered the question about the number of questions. I don't teach on 4th level, but you do have Miss Reljak and Mrs. Johns. So you should, you know, they're great lecturers. You don't need to know, Michelle, about the genetic box thing, but I think that helps you understand about the autosomal recessive genes, which is usually like the little b ones. So you just need to understand what the term means, but that's how it comes about, by doing the genetic box.
And I would compare your Huntington's with your sickle cell because they're both inherited. So you have, and one's autosomal dominant, one's recessive. So I would review that a little bit. And then your Down syndrome is going to be, it's not, it is a chromosomal abnormality where I have that 3rd genome on the chromosomes. So it's different. It's a chromosomal abnormality. It's not genetic in the sense that it's inherited. So I won't see that come up. I can't put that into little boxes. So know the difference between a genetic that's passed on and a congenital chromosomal deficiency.
Okay, so I think it's 2.5 hours you have for the 100 questions. So you have plenty of time. There's no reason to, you know, bebop through it. There's no fire, nothing like that you need to go put out. So try and make sure, you know, just a couple more housekeeping things that, you take it in a quiet environment. You don't have people running around in the background, those types of things, that you're able to focus, your camera is in view. No paper. There's no need for paper on the comprehensive. So you won't need any paper. This is, I don't believe there's a math question on there. And if there is a math question, it may only be one math question, which will be really short. But I don't believe there's any math questions on the comprehensive. Now, I can't speak for HESI. HESI may have a math question. So just be prepared for that you may come across or be asked.
There is math on HESI, we were told that.
There you go. So but you will be able to have a piece of paper for HESI. So
yes.
There's no
yes.
reason to stress over that piece, because you'll be provided with that one sheet of paper. And that was the difference between the lecture exam. The comprehensive, there's no bathroom break. So don't drink all your coffee and all that stuff. And then you have to end up peeing on yourself. So try not to do any of that. For the Tuesday group, or for the Monday group that has a Monday clinical, you'll take your comprehensive on Tuesday. And that was scheduled for, let me make sure I tell you the right time. Someone says diaper. It's so bad. All right, so the Monday group that has clinical, you will take your comprehensive on Tuesday at 11. And your makeup exam date is Thursday at 8 a.m. And that's only for the Tuesday group. For the Monday clinical group. So if you are not in clinical on Monday, and there's only 7 people, if you're not in clinical on Monday, this does not apply to you. Everybody else will be taking their exam on Monday, and their makeup will be on Wednesday. So don't get yourself confused. And if I need to, I will put out a grid and list the names of the people that this Tuesday and Thursday would be applicable to, so that you guys don't say I was confused. So for makeups, you just log into ExamSoft, and the right exam should be sitting there. That is true. If you need to take more than one exam, so say for instance, you missed an exam, and then that's already a makeup, and then you're gonna take the makeup. You need to decide which of those exams you need to let me know on Monday which exam you plan to take first, because the exams aren't gonna be opened up. They're gonna be opened up in blocks of times. So that information, I need to have that, so that way it's open. So it starts at 8 and then it goes through the day. So if you have more than one exam to make up, then I need you to send me an email.
And usually if you have one that you did not take at all, illness or family situation for whatever reason, you probably want to get that one done, because you have to take that one. We have to have a grade for that exam. And then possibly taking that one, doing your comprehensive, you don't need an actual retake on another exam. But the one that you did not take at all must be taken. That's not an option. Correct? Is that right, Ms. Hudson? I think so. Whoops.
I muted myself.
Oh.
and I was talking, and the thing says you're muted. But yes, you need to, I would take the exam that I haven't taken and list. And here's the, I guess it could be the beauty of it all. It would have already been something you've already studied, because you studied for the comprehensive. So all you should be doing now is just reviewing that one section of the exam, or that one portion of your study time for that, for that exam. And then I try to be flexible in giving you a break in between. And then, that gives you some extra review time before you take the next exam. Does that make sense? Comprehensive grades have to be posted on Monday because otherwise it'll take out your whole 24-hour window. Is it too early to ask, but Ms. Johns, which campus are you going to be teaching for? I'll let her answer that because I don't know.
It is probably too early because we don't have a final schedule yet. Is that
That is true. We don't.
We don't know. My schedule usually changes at least 3 times before the semester begins, so I do not know.
There is a couple people that had their hands up, and I can't see who it is anymore. So if you had your hand up, somebody start talking. I'm sorry. Kristen or Christine.
Oh, it was me and Kristen.
Okay.
But I just want to clarify, just to decrease some anxiety. But there's lots of dates and times thrown out there. But so for the Monday group, for this final, our final is at, you said 8 a.m. or is it?
No. Your final will be Tuesday, and I had to go back to the
Oh,
email.
no. The group that's going to be taking their final on Monday.
So the regular group that's taking the final on Monday, you take the final at 11.
Okay.
That's what's posted in your syllabus, correct?
Yes.
I have not changed anything related to that.
Okay, awesome. And then our retake will be on Wednesday at 8
Your
o'clock.
retake will be on Wednesday. There's only, as I said, 7 people. They have Miss Perkins for their clinical faculty. Those are the only folks that'll be taking that exam on Tuesday.
Okay. And so the retake's going to be at 8, you say?
And the retake will be at 8. So both makeup times start at 8 a.m.
Okay. Awesome.
And so both comprehensive times start at 11 a.m. So we're keeping it the same.
Okay.
That's what worked best for for Miss Rattan and Mr. Diaz.
The Tuesday group is at 11 too for comprehensive? I thought you said 9. I'm sorry. No.
I did say 9. He told me that they had to change that to 11. So you get 2
Okay.
extra hours.
Okay, thank you.
Any others? All right, so let me see what other questions there were in here.
When is HESI payment due?
ASAP.
Yeah.
Well, I mean, basically, you take the HESI on the 13th or the 14th. So I would have that 48 hours before HESI is due.
Mm-hmm.
So before your due time, I would pay for HESI. So that may be, you could pay for that on Sunday because your test is on Wednesday to make sure you don't have an issue. But at least 48 hours is what they require. And what's going to end up happening is Ms. Rattan and Mr. Diaz will, also help us verify who paid and all of that. So we need to make sure that we handle all of those pieces. I have already posted, I've already posted the codes, Ashley, and it wasn't an email, it was an announcement, but I need to go back and see because I think there's 3 of you guys that fall under a different code. So I'll double check that for you folks. All right, so have we gotten all the comprehensive jitters out of the way? HESI jitters out of the way? So, I can do a short Q&A just for clarification of, and this will probably be Wednesday because my day is going to be pretty booked on Tuesday. Wednesday, no, can't do it Wednesday because you're taking the test. Well, probably Wednesday afternoon-ish. And I may not have to do a Q&A. I can just post this announcement and put it in your course board, what would need to happen, or if after all of the makeup exams, what your next steps would be. And remember, the Chancellor extended, if you opt to drop, then you can get full 100% reimbursement back. And then you've already taken your P&C exam. I don't think there's anybody that's failing P&C. So you would be dropping lecture and clinical. Yeah, they've asked that. Oh, that's old. I'm going back down. You schedule HESI. I think we sent that out prior, Katie. There was a link that I posted in the course board about what to do with HESI. So go refer back to that. And if you can't find it, then let me know. That's also posted, Stephanie, with the bathroom breaks. So in that form that you signed, the acknowledgement form, and I have not received all of them, by the way, it actually outlines what the bathroom breaks would be. So the true drop date is May 13th. That's what I was getting to. So Chancellor May is allowing students to drop their courses up until May 13th and get a full refund back. I think, and Mrs. Johns, help me remember this, I believe the HESI retake is that next Monday. Do you remember that?
She just put something out yesterday that it would be either the 26th, 27th, or 28th.
Okay.
It would be 2 weeks after you've taken it. But
Okay.
she didn't say which day. We might know more on Monday.
Sounds good.
Yeah.
No, because you would do the, Jocelyn, this is your question. Would this affect your readmit if you were to drop? No, it would not. And I'm not sure what you mean by how it would affect the readmit, but remember, readmits look at the date of when the exit interviews were dated. So that's how that goes. So it's kind of on a first come, first serve.
And I think we said that all of anyone dropping this semester would be a priority 1.
I believe so.
Said. Yeah. Okay, with the bathroom break, it's 1 break, a 5-minute bathroom break. So guys, you shouldn't have any problem. Ladies, you're gonna have to be getting ready on the way down the hall. That's all I can say.
All right, so there's more questions. I am fine covering more material. So there's been a couple questions about that, but I just think comprehensive got started and then we went on to HESI. So people who drop would get back in over people who don't pass HESI. I can't say that. I can't say that. I mean,
I can't say that for sure.
I can't say that would be a for sure.
Okay, as far as what we do about the bathroom, you're going to have a live proctor, so I think you will just say, I'm going to the bathroom. We've not done this before, but that's the picture we were sort of given how it would work, which is why we can't do it with ExamSoft, because we don't know what you left this room for or why your screen went blank, why you aren't within the screen.
So we have a faculty meeting on Monday.
Mm-hmm.
At 8 a.m.
Oh, Lord help us.
I know, with the birds. So let me ask that question. You know, I believe you have to drop both, but I'll double check. This is for Esther, just to make sure. I don't want to tell you the wrong thing, but I believe you have to lecture and clinical goes together.
I think they do.
So there, Kristen asked, lecture and Crystal, listen to me, lecture and clinical go together. So the only thing you wouldn't have to take would be P&C. So you would repeat 3rd level.
Don't repeat it, just.
But you know what?
What to do, you know what to do to be successful.
Right, and this is why I try not to talk about those things, because it's very easy to amp up your anxiety, because your mind starts going down that rabbit hole. So let's just, kind of pump the brakes on this for a little bit. And while we're pumping the brakes, let's go ahead and pump a 10-minute break. And then we'll come back, and then Mrs. Johns and I will get back to whatever questions you guys have. And then we'll, close it out for the day so you can start putting in some quality study time. So we'll just take a 10, and then we'll come back and finish out. Sounds good? Right, this is gonna be about the comprehensive. So let's take a 10-minute break. Is she back? So you guys tell me which one turns your tear ducts, which one turns them orange? If you had to make a educated guess. Okay.
Okay.
All right, yeah, we're back.
Okay, I think, Jessica, you've hit on what's important. We're not going to ask you which one. We're going to say your patient is on these medications. What's your teaching?
Right.
Yeah, absolutely. Good point.
And it's, it could be reddish brown, which is kind of a bricky color. It's not quite orange. So it could be reddish orange or reddish brown. So either or. Definitely no contacts. So you should know the teachings to these meds. And I know a lot of times we quickly rush to GI upset. GI upset can be in quite a bit of them. So look at things that this would, would this impact the liver? Would this impact the kidneys and be a hepatotoxin or a nephrotoxin? Could this cause, autotoxicity? So, those are things that you want to know. Is this someone that can really severely drop a patient's blood pressure? Those types of things are the teachings that you want to provide related to medication administration. It should have millimeters because that's what they're measuring in, or larger lines. I can't necessarily, it should be the appropriate ruler. I can say that. So it shouldn't be something that's oddball. It shouldn't be like in inches. So, what kind of precautions would this person be on? Or would they be on any precautions? Airborne and droplet precautions, absolutely. What mask should you be wearing? N95. Okay, so if you have if a family member, a sibling has tuberculosis, what's going to happen with the rest of the family? So are they going to put that kiddo in a tent by himself or herself? No. Everybody's now going to be, the kiddo would definitely be on meds, but they're going to treat the family prophylactically. So, then we talked about the different tests that can be done and what it means. And we talked about how the acid-fast bacillus, and what is that? It's sputum. So it basically lets you know how much bacteria is, in that sputum, okay? So they will be looking at that to see if your tuberculosis is gone, or is it amping up, or, is it present? And then they'll continue to monitor that. So they usually do about 3 of those sputums, 1 per day when they're hospitalized, to see where the numbers are moving.
You can also, remember, have a patient with a positive TB test that is asymptomatic. We can have inactive. So what are we going to do for them?
Exactly. You know, then we talked about the gold standard.
Yes, we're still going to treat, but we aren't isolating. So absolutely. So you're getting the picture. Good.
You know, we looked at, what is that? The BCG.
BCG, yes.
The BCG, like in Victor. So that could be an option of a testing. And then they have now, I think it's called the gold standard testing. Those that are options. You know,
the interferon gold, yeah.
Yeah,
right.
CT scans. So, and if they're admitted, they're going to be in a negative pressure room.
Right.
So, understanding those components, how would my patient present? What would be the signs and symptoms? What questions we want to ask them? You know, if they're living in crowded conditions, or if they're living, if, you know, someone visited someone that was incarcerated. I mean, I say hopefully now with shelter in, we wouldn't be doing that. But since some of these rules have been relaxed, have they traveled outside of the country? Absolutely. I mean, I am terrified. I'm truly terrified, because every day when they say, oh, we've had 187 new cases, I hope you guys know that was 187 cases 2 to 3 days ago. So that the numbers that they're reporting daily are 2 to 3 days old. Those are from all the tests that was done back then. So, you know, that shelter in place definitely worked, and we should still be in it or on it. Who they infected already? Absolutely. You know, sneeze etiquette, cough etiquette. Three times. What do you mean by 3 times at least? I'm confused. Sputum culture. I'm not sure what, Dianelle, what are you actually asking? Are you addressing the sputum culture? Yeah, best in the morning, yeah. But they're gonna do it 3 times, once per day. But I'm not sure what the 180 times 3 is. We're hoping it's negative, because then they'd be negative for TB. And remember, TB.
I think she was saying that.
Huh?
Oh, I was just gonna say, I think she was saying that that was related to the.
Oh, the spread of 100 interacted with 3 people. Oh, yeah. Okay, I'm sorry. I was slow on the tape. Thank you. You're talking about the Rona. Okay, not the TB. So, what is very significant about TB? Is that a big particle, or a big bacteria, or a small bacteria? It's a tiny one that can stay suspended in the air for a while. So that's the other reason why that cough and sneezing etiquette is important. That, you know, we're teaching them how, you know, how to sneeze, so they're not, you know, infecting that all over the place. But TB can lay dormant. And remember, they have latent TB. So don't forget about the, you know, difference between that and active that we talked about as well. Proper disposal of tissues, yes. So all of those pieces would be appropriate. Where you want to go next? Psych. Oh, we don't have Miss Gordon on, but we may be able to answer some of those questions. Is this free game? Ask any Q. If it's about explaining something, yes. But if it's about a test question, I'm going to answer it in a general standpoint, because I've already covered the highly missed questions. IBD, which part of IBD? Ulcerative colitis versus Crohn's? Okay. So, all right. So what are your questions about ulcerative colitis and Crohn's? Where are your struggles? I mean, because we actually covered that the other day, actually during the Q&A. It is a CT scan for Crohn's. I mean, a CT scan for ulcerative colitis and a colonoscopy for Crohn's. So C and C. So, you know, Crohn's, colonoscopy, ulcerative colitis, that's 2 words. CT scan, 2 words. Does that help you? Okay. Yes, Catherine.
So I know you said you didn't want to answer questions that were related to the test, but as far as the broad part goes, I guess the question was, is an elderly couple is being assessed, something about social interactions. I had no idea what they were talking about as far as social interaction. Like what am I supposed to assess when they're already I don't know.
What do you mean? Social interaction for somebody who's had a loss?
I don't remember that question. I just remember there was the answers that were on there confused me, and then it was something about an elderly couple, and how something about monitoring for their social interactions. What would be? I'm guessing what would be.
I think I remember, at least it's probably was something we did before, but so if you are trying to assess if this is under, I don't know if it was under the aging, developmental, human development, but the fact that you would assess for their social interactions, that's something you want to know if they're aging appropriately. Or if we're starting to see isolation, then we're at risk for the dementia and other things. So we do assess what they're involved in, do they go to the community center, those types of things. So if is that what you're talking about? Related to depression? Absolutely. It would.
Yes.
Yes. Okay. So we do assess for the social interaction, ask those questions. What do they do? Because the more isolated they are, the more prone to depression, dementia, those kinds of things. And I know in second semester, I think we asked that about Alzheimer's, that maintaining social, physical contacts actually are a protective factor. And they provide that protective factor that keeps them engaged just a little longer.
Okay.
Does that help?
Yes. Thank you.
You're welcome.
So going back to ulcerative colitis and Crohn's, because that's where we were. There is
I'm sorry.
no, that's fine. I mean, but
Yeah, go ahead.
he popped in with that question, which was a test question. So Tom has a question about, because Crohn's can be the whole tract, what's the test for Crohn's in the small intestines? And or esophagus. So you have barium swallow, right? As a diagnostic test option, correct? You asked about the esophagus, didn't you? And then I'm not sure if an endoscopy would come into play, but that may be, if you're looking at small intestines, that's usually what they would do, an endoscopy for that.
So diagnostic tests would be based on where they're having pain, maybe? I mean, how do you? They just do them all?
We were looking at the most sensitive diagnostic tool. And so the question was about ulcerative colitis, if I remember correctly. And that is actually a CT scan. So it's not a barium swallow, it's a barium enema. That's the other one. Because that will give you if there's any fistulas. But but for Crohn's, colonoscopy would be a very good one. They could do an upper GI series, and that would be another method that they could look at. CT scans, they could do that as well. So it depends on, you know, if they're trying to look at the whole gut, then they may do several diagnostic studies. But usually, although it can affect the entire intestines, it's usually in the large intestines. Does which one stop at the stomach? So if you're doing you can do a barium enema, that will go all the way through. So you have to let that sit and wait. And then you would do a radiograph of that. But that will let you know if there's any fissures anywhere, any fistulas anywhere. So it'll look at the bowel. You can do an MRI. But endoscopy, colonoscopy, sigmoidoscopy, those would be your main go-to diagnostic procedures. So endoscopy looks at the throat all the way to the stomach and a little in the small intestines. Sigmoidoscopy just looks at the area from the anus and the sigmoid area. Colonoscopy goes all the way through. No, that was CT scan. Am I not correct in that, Mrs. Johns?
If I have that, it is for you. You're right. Yeah, that's correct. Yeah.
That ulcerative colitis is CT scan?
Yes. Again, you're looking at
More sensitive.
Yeah, if it's ulcerative colitis, do we want to put something into the colon?
No.
Exactly. No, no, no. Because of the risk of perforation, of course. Bleeding, yes, yes, ma'am.
Okay, so questions on the table about megacolon, toxic megacolon. So wouldn't you have to have like abnormal white blood cell count?
It's an inflammatory condition, so think of what your symptoms are with inflammation. Right? Because it's dilating, expanding.
Mm-hmm. Okay. So basically a rigid abdomen. So signs and symptoms of shock. But I think this person was asking in relation to lab values, and correct me if I'm wrong. You know, it would be those signs and symptoms in addition to an elevated white blood cell count. Okay, so Michelle has your signs and symptoms there in addition to Jessica, and then I've talked about white blood cells. And then they can also do a stool culture if, you know, to determine the bacteria so they know how to treat it.
Whoops, forgot to unmute. One of the big contributing factors to megacolon can be C. diff, so that we definitely want to look at a stool. What do we have going on? That was first semester, we talked about that. I expect you to know it all, right?
Have to carry that knowledge forward.
We sure do.
Okay, I'm just trying to scroll back up.
Would you have decreased bowel sounds or increased bowel sounds with toxic megacolon? You're distended
If
and
it's distended, wouldn't that be like what would that present like?
like a blockage, and you would probably have a lot of bowel sounds, I would imagine.
If it's, yeah, because they have a lot of diarrhea. So usually when you have diarrhea, things are moving through quick. So unless there's an obstruction, then we'd be looking at something different. But there's a lot of bloating, there's a lot of tenderness, there's diarrhea. It could be bloody diarrhea. The bowel movements could be painful.
Listening to the bowel sounds would help you isolate a little bit more what's going on. So it could be either way, depending. Usually we're going to see very hyperactive because of all the gas and the diarrhea and all of that. But if there is an actual impaction or obstruction, we will lose bowel sounds.
Yeah, I think when they're starting to have an obstruction, then that's gonna flip.
Yes.
Increased bowel sounds initially. And then once it starts, if it's not treated and they end up with an obstruction, and it could be apparent, once they have a bowel obstruction, then those bowel sounds are going to diminish. Because remember, you get all that distension above the blockage, and then below it, the lumen gets narrow. Okay. But is a question for you guys, is ulcerative colitis and Crohn's considered an ADA condition? American Disabilities Act condition. Yes, it is. And if those people have, if they're working, their desk needs to be near a bathroom that they can get to very quickly with minimal usage thereof, if that makes sense. Meaning you can't have like one stall, because if somebody's in it and you can't get to it, that's a problem. Okay, so I'm scrolling back up. There was a question about UC. All right, so let's talk about anaphylaxis. For some reason, we're still struggling on what we need to do for anaphylaxis. And, even though we discussed this in the Q&A on Wednesday. There was a question whether you do epinephrine first or oxygen first. And so, we need to treat the problem. So even if you give them oxygen, that doesn't mean that's going to fix the problem. So, and I don't think I shared this with the group, but I had a patient that was allergic to shellfish, ate at Red Lobster, did not order a crustacean, ordered chicken. Didn't realize the grill, the grill that they normally use for crustaceans was down. So of course they're not going to close Red Lobster. They're going to use the only grill they have. So there was crossover. Patients stated they had some tingling in their throat, and they just wanted to get checked out to make sure that everything was okay. All right, so the patient had oxygen and received diphenhydramine. So what you guys are anticipating, that if someone has an anaphylactic reaction, that reaction is actually happening outwardly. Well, for this patient, it actually happened inwardly. So by the time that was caught, because we never gave him epinephrine, so we gave an H2 blocker, famotidine. We gave diphenhydramine, IV, didn't give any epinephrine. And probably about 2.5, 3 hours later, the patient's tongue was protruding through the mouth. I mean, like way out there. So by then, the airway was closed. So all that swelling happened internally. So oxygen didn't necessarily help this individual. So will they need oxygen? Yeah. But does it stop the anaphylaxis? No. So our key is to definitely block the histamines. This is why we give an antihistamine. But we also want to stop the swelling, the vasodilation. We want to stop, which the vasodilation is going to cause a drop in blood pressure, heart rate. We're going to stop the bronchospasms. So this is, no, he did not survive. The man died. It was tragic. Okay. And you don't give EpiPens in the hospital. You're going to be drawing up some epinephrine, preparing that so they don't have it Johnny ready on the spot. They do have some injectable epinephrine, but that's usually 1 to 10,000. But we're not giving that one. We're going to give the 1 to 1,000. So just kind of food for thought, when you're looking at that. An allergic reaction could be local, but anaphylaxis is not local. It is systemic. It affects all body areas, several organs. So it's within the system itself. We cannot give Montelukast because that is not an emergent drug. Okay, so that's the reason why Montelukast is not recommended. But we also need to consider about the inflammatory process, which is why we give them a corticosteroid. So I think there was some confusion about what should you do. Anaphylaxis, now pre-hospital, or any lay person that's allergic to something, and if they come in contact with it, they're going to give themselves, epinephrine through an EpiPen. So that's how they're going to handle it. They're also asked to carry Benadryl to help with the histamine component. They can't carry everything, but they're at least trying to minimize. Those are usually the top 2 things they'll have in their kit. And they may have more than one EpiPen. So that was kind of the, just kind of the general understanding about, anaphylaxis. We have to treat the problem. Does that make sense? And I think they brought that down to a kiddo, and it asked about signs and symptoms, but with the vasodilation, we're going to have decreased venous return, which means our heart rate and contractility are going to be low. The medication order after epinephrine is going to be doctor dependent, and it doesn't really matter as long as they get it. I don't believe EpiPens are reusable, but I believe that there are some that has multiple injections built into the system if needed. There are a couple like that. So hopefully this clears up the whole dual dose EpiPens, yes. So are we good now on anaphylaxis? So I'm not saying that oxygen will not be done, but it's not the primary thing first. Now, if that was a select all that applied, then those 2 things would definitely be applicable. Oxygen and EpiPen. But I think it was a priority question. So other types of allergic reactions could just be from bubble baths, washing powder, like washing machine, laundry detergent, things of that nature. Scented soaps. So some soaps, some folks can only use Dove. Some people can only use Ivory. Some folks have to use like herbal soaps. So it just depends. So an allergic reaction, Martin, could be like poison ivy. Does that make sense? Okay. Now, if you stepped on a colony of ants, you may have an anaphylactic reaction because those little boogers attack with a vengeance. And now you have, venom that's being injected into your whatever area they're biting the stew out of however many times. All right, so that was IDB, anaphylaxis. We did toxic metallocolins. I'm scrolling back up to see what were the others. We covered that. All right, cerebral palsy. Did you want to address that, Mrs. Johns?
Sure. So what are you?
It's at the types.
Okay, types of cerebral palsy. I can't say for sure that it's on or not on the test. I don't know that. But I would know the most common type, and I think you have the PowerPoint that has the types listed, and usually the spastic is what we're more apt to see. But even know the sooner we diagnose it, of course, the better the outcome for the child. So early intervention, so there's you have the list of your signs, what you're looking for. And again, they're different than they should be. So they're inconsolable. A baby that can't be consoled is a red flag. And no interest in their environment, that's a red flag. So you have to know sort of the developmental stages and what would be expected, and knowing it's outside of the ordinary. And then what is our goal for treatment? What is our goal? And that'll help you know where to take your interventions. What's your goal for a child with CP, no matter what type they have? Okay, to be as independent and self-sufficient as possible. Function, absolutely. We have a focus on function. And in order to become as independent as possible, means we have to provide the cognitive abilities for them, test that and provide that so that they are developing like we would expect them at all the levels. And I know on your human developmental slide we're talking about has the ADHD and autism in it, but it gave you the categories, every type of development, every area that we're looking for, and we're looking to maximize that for our child with CP as well. What is another main goal? Function, absolutely. Being able to meet their growth and developmental. We want to do it within what kind of a context? Safety, there we go, absolutely. We have to maintain safety, so if it means, Jessica, that we're using assistive devices, absolutely. If they have spasticity, then we want to use the same things that we talked about with Parkinson's, using a larger type of utensil to eat with so that they can control it, using adaptive and being adaptive. They might need a helmet, they might not. It depends on what the safety issues are. But we're looking at that. Definitely joint and muscle. They're going to be in some type of rehabilitation, physical therapy, occupational therapy, all of that is part of your management team. Language, speech, therapy, all of that's going to be part of their management of for CP. But the goal, of course, is to as much independent self-sufficiency as possible, maintaining their growth and developmental. So putting those cues in so they're not isolated, not getting the social interactions, that's important for them. And then above all, helping them, keeping them safe.
So Ms. Johnson, I have a really quick question. So cerebral palsy is a neuromuscular disease, correct?
Is a what?
Neuromuscular.
Yes.
Can it also be, or does it include any cognitive impairments?
It can. It is a huge variation. It absolutely can, which is why we're going to be monitoring their growth and development. And that's why I said, look at that PowerPoint from human development from the very first unit, and it lists all the areas, physical, motor, language, social, adaptive, lists all those. I don't know if I got them all, but it lists all the areas of involvement and development for the child. So all of that we're going to focus on meeting those goals as much as possible.
Right, and then I have a note here that says early treatment, like you said, for the child has better outcomes of overcoming developmental disability. Developmental disability in regards to like their functionability, or because I would assume that if you start, using assistive devices early on, they might have a little bit more independence maybe, or more function.
Yes, absolutely. And the same thing, if I'm using early and I'm intervening early and they're in school with their adaptive devices, my social development is progressing along those lines as well. So it's meeting, like I said, every one of those areas of development for them.
Okay, perfect. Thank you.
And the only one that isn't cognitive is MS. I'm lost. I'm sorry. MS, the type of CP? Are we still talking CP?
No, I was just talking about because there's the muscular sclerosis. Yes, that's what I was talking about. Is one of the neuromuscular diseases that doesn't affect your cognitive ability, right? Just to clarify between that.
Let me see. Lupus does. Maybe I'd have to actually
I don't
look.
think MS does.
I don't think so either. I know when we did end of life, the thing that stands out is, of course, ALS, because they're cognitively very aware and sharp while their body is failing. But does that answer your questions on CP? Are we good?
Yes. Yes, it does.
Right.
Thank you.
You are welcome.
I'm just going to address, there was something in the, Courtney she asked the question, and I'm not sure if this is where this came from, but she said it was a chart like 15 different chemo drugs. I don't see it listed in your course unless it was something provided separately, but there was a question, a matching question on the exam that covered those agents, Courtney. So the article was the chemotherapy primer, and then that's kind of the same chart that's actually in your book. So it's just kind of understanding the classes and what they do. And it really does, I won't say it really doesn't matter which chemo medication they receive. What I mean, and when I'm saying it, I mean from the standpoint is once they are on chemo, patients respond relatively the same way, where they're going to be immunosuppressed, they're going to have nausea, vomiting, they're not going to feel well, they could have acute kidney injury. So that could be with any of the chemos. Does that make sense? Now, how they work is a horse of another color, depending on what type of cancer the individual have. So they may have a mono versus a combo therapy. Does that make sense? Okay. So Michelle, you're saying it was a PowerPoint. Is that for the same thing about the chemo, or is that for something different? Okay, so again, I would not right now focus on, a specific drug. Those are things that can usually be asked unless it's something super common. And if it was directly related to like breast cancer, and this was a common one, but all those chemotherapies are different depending on if it's in situ, if it's in ductal, is it metastasized, all of those different things. And once they go to, if you have, again, so we'll take the person had colon cancer and it went to the lungs. So if for some reason it now pops up in the liver, the cancer's in the liver, then the therapy for that's going to be different. They're going to have to adjust those drugs. So just kind of having that understanding and how this can impact the patient, emotionally, and supporting that individual. Now we had it in 2 places, now it's in a 3rd place. So now we got to do more chemo. So it's from that standpoint. With the unit exams, we can get more specific because, we have we're only testing those exemplar areas. Whereas when you have the comprehensive, we can't put everything on that test. Otherwise it'd be a 300-400 question test. So we are trying to go from start to finish and have questions from, and there'll be questions from every concept, every exemplar. We're not going to miss one. It just won't be the ones you've already seen. So does that make sense? Okay, so I'm going to go back up just to make sure I covered everything else before we got to the CP question, because it seemed like we went backwards. Okay, we did the MS. Okay, we talked about that. Covered. Spinal shock and neurogenic shock. So which one's going to have the widespread vasodilation? Would that be spinal or neurogenic? That's going to be neurogenic. So if you're looking at spinal shock, what type of injury would you had to have had? Spinal cord injury. So here, there's going to be some type of dysfunction of the spinal cord. So they may have, some initial losses in reflexes, like in the deep tendon reflexes, and then, have loss of the sympathetic outflow. So we're going to be monitoring for, that. You're going to look for both spinal cord injury and spinal shock and neurogenic shock in your spinal cord injury patients overall. So we're, a couple days later, some swelling and things may go away, and they may be in a whole nother process. But some books classify spinal shock and neurogenic shock as the same. So I think there's a very fine line between the two. But neurogenic, I can't talk right now. Neurogenic shock, they're going to have that widespread vasodilation, which means their blood pressure is not going to be elevated, it'll be low, they'll be bradycardic, because that sympathetic nervous system process has been disrupted.
So Ms. Hudson, I have a really quick question. I know that there's, maybe you can clarify on it a little bit, but there's a specific injury, and I believe it's usually between C1 and C8, that where it affects respiratory dysfunction, and the patient may have to be like on a ventilator or mechanical ventilation. Would you agree with that, or is there a more specific injury?
All right, so if you have a C1, which is a cervical 1, cervical 2 injury. So say, for instance, a person hung themselves, so they're going to have a distraction injury, which basically means that person is not going to survive. The phrenic nerve that's located between cervical vertebrae 3 through 5 is the nerve that's used to innervate the diaphragm, which means it's going to allow the diaphragm to flatten and move and all of that to help support respiration. So the higher that cervical spine injury is, the more likely they will be on a ventilator. You know, the lower that cervical spine injury is, and it depends on how bad the cervical spine is injured and how bad the phrenic nerve is injured. So we'll just say C3 to C5. They're going to have respiratory compromise, and that could be, you know, they're going to have to be on high flow oxygen, to they're going to have to be bag valve mask, and then, you know, require a ventilator to sustain life. So it just depends on, you know, it's going to depend on two things: location and the severity of the injury. Does that make sense? Treat the problem, Michelle. So the priority intervention for autonomic dysreflexia is treat the problem. So if it's the person hasn't defecated, then we're going to evacuate the bowel. If the person hasn't urinated, then we're going to empty the bladder. If the blood pressure is too high, if it's because of blood pressure, then we're going to treat the blood pressure. If it's hypoxia, we're going to treat that. So we're going to treat the cause. So first you have to determine what the cause is in order to treat it. Uh-huh.
And then something super quick. There was a mnemonic for the manifestations for systemic lupus. I cannot remember it. And I have it but it's kind of choppy. So I don't know if you remember it. So.
There you go. So do you know what SOAP is? So serositis, oral ulcers, arthritis, photosensitivity, right? Nope. Someone says nope. Is that like you don't remember, or is that serositis? SEROSITIS. Someone says Google SOAP brain. Isn't it SOAP brain MD? Because they also look at the different types of rashes. Okay. Go back up and see. I think. So Kristen, if the breast cancer metastasized to the liver, it's the same breast cancer cells that is now in the liver. But since it's in the liver, we can't treat it with breast cancer chemo that we would for breast cancer. Does that make sense? Because different organs respond differently to chemo. So they would have to start another regimen. Next area.
Ms. Hudson?
Yeah.
So just to finally wrap it up, sorry, there's been discussion with a few other students. Is there a quote in the, we're still confused about CT versus endoscopy for ulcerative colitis or Crohn's. I quoted from the book, page 709, which is in the readings assigned. It says, diagnosis of ulcerative colitis is based on history and physical examination. The diagnosis is usually confirmed by sigmoidoscopy, colonoscopy, biopsy, and negative stool examination for other infectious or other causes. Whereas you said, don't do a colonoscopy for ulcerative colitis. And then under CT, it said,
what I said was this: the CT scan was more sensitive than those three.
well, the book doesn't mention CT for ulcerative colitis, but it does mention CT for Crohn's.
Okay, let me go to page 709. Hold on.
Crohn's is on 708 right before.
Okay, let me go there real quick. Hang on. And so while I'm going there, are there any other questions besides that one? To answer that question, Dianelle, they would draw labs and everything first. And they may do a guaiac to see if there's any blood, and then they would do those diagnostic procedures. So I'm just trying to get to the book real quick. So let me go to the ebook, or to my Vita source. There we go. We have not discussed depression, but if you have a question, go ahead and ask that. If for TB, those would be correct. So if you have an immunocompromised patient, then they don't have to have a bigger millimeter. Anyone, yeah. All right, so I am in, let me make sure I'm in the right book. Okay. I'm in Runner.
I mean, if you want, it only has one paragraph each for diagnosis, and I can just copy paste them.
No, I got it. For the correct, you need to confirm. Your TB skin test only tells you that you've been exposed. It doesn't tell you whether or not you have active TB. You have to finish out the rest of it. So that means get a chest x-ray and all of that. All right, so I'm not sure, you said page 709, but when I go to your textbook, it's actually 1331.
The pathophysiology textbook?
No, your Brunner textbook.
Well, the reading is assigned from the pathophysiology textbook.
I'll go back to that in just a second because I didn't go through concepts. I just went directly to the book. And it does say colonoscopy. Colonoscopy is the more definitive test there on 1331. Although it lists all of the others, but it says which one is more definitive.
Was that for ulcerative colitis or for Crohn's?
For ulcerative colitis, so that way you can hear me. It says, and I'll read it. Assessment and diagnostic findings. So abdominal studies, they can do all that. Colonoscopy is a definitive screening test that can distinguish ulcerative colitis from other diseases of the colon with similar symptoms. So that could be any other symptom. It may reveal friable, inflamed mucosa with exudate and ulcerations. Biopsies are typically taken to determine histological characteristics of the colon tissue and extent of the disease. CT, MRI, and ultrasound studies can identify abscesses and perirectal involvement. And then it talks about stool cultures, etc. So now I'm going to scroll down and see if Crohn's is after that or before. That's going to be before. So it's going to be before 1331. All right, so Crohn's. It says, however, this study has fallen out of favor. This was a barium study in upper GI series, have fallen out of favor with the introduction of improved CT scan. So Crohn's is CT and UC is colonoscopy. So for clarification.
Awesome. Thank you so much.
You're welcome. So thank you. But that's also on 1331. So 1331 on the electronic version, and then it still says 1331 for ulcerative colitis.
Of which book?
Brunner.
Yeah, that's, like I said, I was looking at the patho reading from the concept.
I'm going to go through and see from the concepts view. So let me go back there to see if there was anything else, if I missed something. So hold on. I'm going concept view now for immunity. So my apologies.
No, it agreed perfectly between the two books. I just needed clarification between what you and Ms. John said.
No worries. All right, so let me go through your concept view. Immunity. So under immunity, it does list 1332 for all of your inflammatory bowel disease, ulcerative colitis. So I'm not sure where in addition to 705 to 709, but your textbook is there and you said it wasn't, but it is there.
Oh, no, I didn't. I was just saying that the one I looked at was from the reading, which is the 705 to 709 in the
But
Pathophys
it's
book.
also your reading, 1322 to 1336. So it's also in the med-surg book. So there, it's the pathophysiology book is there. I am agreeing with you on that, but I'm also saying that it's also in your textbook.
Yep.
1322 to 1336. Because how I interpreted what you were saying was that the Brenner book did not have ulcerative colitis and Crohn's in it.
Oh, that was a miscommunication then. My apologies.
No worries. It's all good. Can we confirm with AFB correct or X-ray? Thanks. You need both, but if you want a more definitive, your acid-fast bacillus would be there. And if you have a positive skin test, then they will follow up with a chest X-ray to see if they see any infiltrates in the chest X-ray. But if you want a definitive process, you know, where it is, if it's continuing to grow or not, then that would be an acid-fast bacillus to get more specifics. Okay, so we got that cleared up. What's your next question? So my apologies for getting the two confused on the diagnostic studies. That's it. Yep.
Remember, your DI is your pillar of salt. So they are hypernutrient, but no fluid. So they're thirsty, drinking, peeing, losing fluid and retaining sodium.
Correct.
Correct. Mm-hmm.
I think in the overall pieces of that, you can't let the DI and the SIADH go from second semester because of the TBI, traumatic brain injury, that you see in third.
Which you address again in fourth, so hang on to it.
Ms. Hudson, I have a question. Unfortunately, it's in relation to IBD yet again, but I just wanted to ask if the patient was having, persistent diarrhea, would we be concerned with the diarrhea or the fact that they could become hypovolemic?
Okay, so that's a very good question. Focusing in on the diarrhea. So if you stop it, have you fixed your volume problem?
I want to say yes, because now you're not going to lose anything, and now we can just focus on correcting the loss of fluid.
So you're going to be dehydrated first, though.
Right.
So my question is, even if you stop the diarrhea, if that's your first intervention, have you fixed your problem?
This is true. You are still dehydrated. So yeah, I guess you would fix the fluid electrolyte problem first. That might help.
Dehydration problem. because, you know, if you can at least get their volume up, you don't want it. So say you stop the diarrhea, but they're still hypovolemic. So their problem is the hypovolemia because of the diarrhea. So let's correct our complication, and then we can correct our diarrhea problem. They have shock. They can go into shock because of loss of volume. But the reason why they're having loss of volume is the diarrhea, but we need to replace volume. We can fix the diarrhea.
Correct.
So if we only focus on the diarrhea part and we leave the hypovolemic part off, then we're putting the patient at risk because of now electrolyte imbalances as well. Yes, water follows salt. That's right.
All right, I am going to excuse myself. I have to go elsewhere right now. So thank you all.
And it is 1:07.
Yeah.
So this would be our break time. So we're both going to sign off.
All righty.
You guys are welcome.
Thank you for taking time to ask these questions. And
Sure.
we'll see you later, Monday.
Bye, guys.